Thank you, ma'am. Thank you for your detailed presentation about the NAM scheme, its present status, and what is the expectations from the ministry. Your very well thought uh, recommendations and suggestions. Now we will like to request our Atul Kotwal sir for sharing his views and for such good thoughts. And
Thank you, Mr. Viswas. Respected Secretary Ayush, Padma Shri Vaidyanathan Rajesh Kotecha sir, respected Kavita Garg madam, all the respected secretaries of health and Ayush from states and the entire state teams, the NAM team as such, very, very motivated, committed, and we keep on having regular discussions also. And always a pleasure to be part of those discussions and all the participants. I was watching intently when the presentation was being made by the CCA, and despite the post-lunch session, everyone was very, very awake and alert. So money keeps us awake, whether it's ours or Government of India's. That's a great thing. And but now is the time, the glucose surge would have probably, but I'll be quick and short because I too got a flight to catch at 8:30 in the evening from Pune. Uh, Coming to the capacity building as such, but I would like to share with you that my job has been made very, very simple and very easy, courtesy the excellent discussions and all roundtable which we had in the morning. You all shared your views and your areas of work, and it was a great cross learning for all of us. And for someone like me who's not regularly working with Ayush, but then we have been having interactions, and also, as I mentioned earlier, in NHSRC, we make an effort to include Ayush in all our policies making and all our discussions with the ministry, and also when we go to the states. And that's why common review mission, which we undertake in my NHSRC, basically organizes it. Ayush is an integral part of it, and the TORs are shared with all the states. And even those, the entire team, we have Ayush personnel as part of each team, but the other team members also look at those aspects. So it's an integrated kind of look at the health systems. So capacity building for the health systems, capacity building of Ayush for the health system. That's the topic of my talk. But another thing I would like to share with you is that in 89, 90, when I was doing my MD BSM, there's a time two of us, me and another colleague of mine, were selected by the then Commandant FMC and the Army Commander at that time to conduct a study on yoga and its effect on blood pressure and blood sugar levels. So we had a randomized trial of the young, fit army soldiers in Pune cantonment that time. And there were very interesting results at how the BP levels came lower and also sugar levels came lower. Even those who were healthy to begin with, because all soldiers were healthy. We didn't take anyone who was suffering from any kind of disease. Of course, we never published it because it being a government army data at that time. But my association with Ayush is continuing from then. When I was in All India Institute of Medical Sciences for doing my postdoctoral in 2000, that's the time I conducted a lot of research methodology workshops. I remember going to Janakpuri Institute also once for a 3-hour session. Otherwise, we used to get students from various institutions from Ayush to All India Institute of Medical Sciences and conduct workshops, research methodology workshop. That's another area of work close to my heart. When I was in Planning Commission 2006 and 7, and when we wrote the 11th plan, there's a time Dr. Darshan Shankar was the advisor Ayush in Planning Commission, and we used to work closely together. And we increased the fund of Ayush fivefold. But as we all are aware, the utilization was not much. At the time, we thought of drug parks and all, giving all kind of facilities, but linked with quality assurance. But very heartening to see from 14 onwards how the funding is increasing and how it has been utilizing also. At that time, there was a study conducted by NHSRC, which was quoted later on before the formation of the National Ayush Mission and Ministry of Ayush. The study was Status and Role of Ayush and Local Health Traditions under NRHM, and published in 2010. I am honored to share that I designed that study. I was part of the team which finally analyzed and wrote that. My name is not there as a co-author because I had not taken permission from the army. That's why my name could not be there. My name is there in the acknowledgement. So that's how the armed forces also work sometimes. Anyway, so about NHSRC, quickly I'll share with you so that all the four groups which you made. In case you need further interactions or discussions and all, also we are always available. So looking at the entire health systems, I have 8 technical divisions in Delhi. Community processes and comprehensive primary health care. One is human resources for health and health policy integrated planning, healthcare technology, healthcare financing. We also prepare national health accounts, and where Ayush is part of that because total health expenditure includes everything. Quality and patient safety, the NQAS program, which I alluded to earlier, the public health planning, public health administration, IT division, and knowledge management division, and of course, an administration division. I have a branch in Guwahati, regional resource center for Northeast, which is a micro cosmos of the NHSRC, mirroring that. So we are guided with equitable, accessible, and quality healthcare for all. That's the overall vision, and that's how we work with the central government and also all the states. So we are a think tank, but then think tanks are not effective till the time they don't get on the ground and learn. That's why we keep visiting the states and learn from there the challenges, the implementation, and also success stories. So if you see the multidisciplinary team I have already shared earlier, I have Ayush in my each of my technical divisions and also in RRCNE to make sure that we get their inputs. The national policy also, I'm not going to go into details of that, but key principles, if you know, the equity, affordability, universality, patient-centered quality of care, accountability, and all, inclusive partnerships and pluralism. That's the word which I think we all have been talking about since morning. Integration and pluralism, how to leverage each of the systems and make sure that people have the choice, and they are empowered enough to use that choice for the system which they want for better outcomes. The vision again for Ayush integration, just to share, I think you all are aware of it, you are working in it. But for people like me, we keep on reading it again and again, that from standalone to integrated, that's point 3.3 in NHP. And I repeat it again because I was part of the initial committee in 2014, which is government formed to write the national policy that time, which came out finally in 2017. And that's the time we started discussing about Ayush. But then point 9 is drug quality control. Again, it was discussed earlier. Infrastructure enhancement. And point 9 is capacity building again. So coming to the main this thing of my talk, capacity building. If you see building blocks of health systems, if you see, as per WHO, there are 6 building blocks. One of them is human resources for health. We have added the 7th from NHSRC, and that's important for Ayush also. Community processes, communitization. Because we talk about accessibility, we talk about affordability, we talk of availability, we talk of equity, we talk of quality and safe services. But if we don't talk of acceptability, we will not be able to achieve what we are now looking forward toward the universal health coverage. Rather, I would use the term universal health care. You have to go beyond coverage. Coverage is now there in Ayushman, Raghuvinder, and PMJ, but now beyond is universal health care for everyone, and that's where the pluralism and integration also comes in. So for HRH, the major issue is not only the numbers, the place where they are required, and in colloquially, what we call is quality, the quantity and quality. And for the quality as such, the capacity building which we need to look at. And since Ayush value is a valuable national asset, all Ayush resources, we have more than 7 lakh plus 7.5 lakh Ayush practitioners, and with the institutions and all which are there. So under NHM also, we have Ayush practitioners. We have more than 14,700 Ayush MOs under RBSK, which is a very, very important program of this thing of looking at the 4 Ds: developmental delays, deficiencies, disorders, and diseases. And that starts from very beginning of when the child is born, and also includes the school health also is part of that. And we are now also looking at leveraging further these RBSK resources to include them into the IEC and BCC campaigns also along with this. We have more than 10,000 Ayush MOs in co-located facilities. And I was discussing with Secretary Sir in the afternoon that of almost 29,000 PHCs and 3,000 plus CHCs and 700 odd, more than 750 odd district hospitals. Out of that, we have only in 10,000 we have co-located, whereas IPHS standards mandate that we should have. So we should look at work towards that to include more. Again, pharmacists and paramedical staff are also there as such. And the CHOs, 8% of the CHOs, community health officers out of 1.29, 1.3 lakh are Ayush background. Some states have got Ayurveda, some have Unani, some have Siddha. J&K has Unani, and southern state one of those has Siddha also. And we also looked at the task shifting which took place during the COVID as part of the Empowered Group 3, and where we made the clear guidelines at how they should be leveraged, and they were from not only prevention and promotion, also cure, also at primary level, and even at secondary level, working as part of the healthcare teams. So, and now looking also at the global presence and all, and medical value tourism was mentioned earlier. So this topic basically now, what we now, I'll be highlighting few bullet points now. One is that there is inequitable distribution with shortage in certain areas of Ayush. Other is role ambiguity within the mainstream public health systems. Skill gap, especially in public health, digital health, health program management. Limited career progression for Ayush professionals when they join any kind of stream. Need for standardized and modernized training for future ready Ayush team, and address all the only the hypertension, diabetes, maybe beyond all the NCTs, and also as agents of change to begin with. So that these are the few points on which I'll be highlighting some aspects of that to to ensure that access to quality care is there. And the what is being done now, IPHS, you all are aware, we have IPHS for allopathic system and IPHS for Ayush also, where I mentioned in the morning that we have provision of Ayush medical officers at each level of facility with co-location. And the objective of Ayush IPHS is also one of the objectives, capacity building and training. And drug diagnostics again, to see that in co-located facilities, how we can increase its drugs and diagnostics also. The quality assurance, I'm very happy to note about the NABH and accreditation of this thing. We are behind because Honorable Pradhan Mantri has given us the target of 10% NQA certified by December 2026 and 50% by December 25. We're working hard towards that. So capacity building, number one, I'll come to public health management cadre, which is there under the National Health Mission. With four streams: the specialist cadre, public health cadre, health management cadre, and the teaching cadre. Teaching cadre is as per the National Medical Commission (NMC), and the fifth one which we are creating now is nursing cadre. So Ayush practitioners have got with the public health background. That's why the public health teaching is required now, so they can be part of the health management cadre. It will not only help the National Health Mission, also help the National Ayush Mission, as ma'am also just now mentioned about the program management capacities. We have a lot of institutions of public health in the country. The quality ones can be leveraged. The MOUs can be done by the National Ayush Mission so that the Ayush practitioners can go for courses. Those who are already serving can go for some short-term courses. They can be tailored. And those who are yet to join, they do full-time, 1 to 2 years, 2 years MPH full-time. But those who are already working, their public health knowledge can be strengthened by 6 months to 1 year courses, and which could be, a lot of it could be contact program also. The other is, when we want to align the Ayush with universal health coverage, the career progression as such, which is very, very important now. So under the public health management cadre, we are now requesting states that has to be a career progression as per the qualifications and experience. Even with the contractual staff, starting from a non-financial kind of structures, we can make those cadres, and subsequently, as and when funds are there, as we are requesting states to spend up to 8% of their annual expenditure on health, which also will include Ayush, and maybe more than that when we talk about Ayush. So how further these can be, these permanent posts can be created. The other is this detailed mapping of existing Ayush workforce. Before we start for the capacity building, this detailed mapping needs to be done. And as Honorable Minister, you also mentioned, not only those who are formally qualified, even those other also who are working, their mapping also, because when we talk of the pharmacovigilance, which Chairman NMC also mentioned, which is a very important part which we need to now work at, and again capacity building on pharmacovigilance also for all Ayush, which we are now starting to do for medical officers also. So all enrollment of all Ayush personnel in the professional registry of ABDM, their health professional registry, and all Ayush facilities to create the health facility registry, so that they are part of the ABDM for longitudinal records. And this longitudinal recording will also help the Ayush professionals to also track when anyone comes to them that what other treatment the individuals are taking, what allopathic treatment they are taking. And similarly for the allopathics also, they also know what other treatments been taking. And that probably will a way to integrate further as such for treatment and management. Merit-based recruitment process, and that's why capacity building. When you do the capacity building, it has to be linked with the merit-based recruitment process, rational deployment. Service delivery gaps need to be looked at. What all services are required, And I like the idea that probably conditions which are known and some kind of specialities, some short courses can be made. Like the other day, we had a discussion with Kavita ji and her team about training all CHOs and ANMs for yoga, and there were very few experts whose numbers you could give us, you know. So whereas now time has come that probably such short certification courses for 500 hours, which can be 6 months, but we can do it in 4.5, 5 months also, which we are doing. Bridge course, which is done for CHOs for the all Ayush whether nursing. Those kind of courses can be planned where specific diseases or ailments can be looked at. Like we are now looking at for task shifting, like LSAS and CMOC, you all would have heard of. That's a task shifting approach where MOs were trained, and that's for the great help in reducing the maternal mortality and infant and neonatal mortality in UP, Bihar, and few of the northern states where these numbers are there. Similarly, for Ayush, such kind of certificate courses need to be looked at, not only management but also like NCDs, specific areas of NCDs, what in which they can specialize, and even communicable and emergency and even cancers now, which we are looking at in a pluralistic kind of framework. The national competency based training frameworks need to be developed to develop clinical skills for effective patient care and also community health part. That's what when I talk about the seventh building block, which we made community participation. That's where a lot of Ayush practitioners and even traditional ISM, when we talk of, they are close to the community. So how they can involve the community for health, for better health, as we all are talking about, from illness to wellness to well-being, and also now happiness has also been added. So how we can leverage Ayush practitioners, but that for that also they'll need some kind of capacity building of how to interact with the community, how to interact with the local leaders, not only community-based organizations, also panchayat and zilla parishad, and also the MLAs and MPs. How to interact with them? Those kind of soft skills and skills need to be trained. So those kind of courses, short courses, can also be made. The health management cadre I have already mentioned. For training, you also need to have infrastructure. You have a lot of institutions, but then again, to teaching capacity of Ayush colleges, academic autonomy for these, and emerging health priorities I have already mentioned. Faculty development programs also are required now with the competency-based medical education. Similarly, competency-based Ayush education, when we have faculty competence is required, which even NMC is also looking at. So that kind of competence for faculty is required now to as we proceed. Training in research methodology, which I mentioned earlier. That's and we had a discussion with sir and I in that 2022. But again, sir, very heartening to see. 2021 March I joined. I think similar same time you joined, and you have been there from earlier. But last 4 years, tremendous progress has been made. I remember that Chintan Shivir chaired by previous HFM it was held in NHSRC on first floor of a hall, and since then the kind of the visibility and the kind of change which has taken place on ground is really commendable, sir, and commendable for you and your entire team. So there the although Ayush has its own paradigm of research, but with the current paradigm of research world over of evidence-based medicine as such, some evidence has to be shown somewhere where we say that okay, these are 5 to 10 or so diseases or conditions where we have shown, we have done this cohort, we've done this randomized control trial, meta-analysis has been done. Now in future we'll look at Ayush way of analyzing the paddhatis, and we'll generate further evidence on that. So that I think needs to be worked more. There are a lot of journals, articles being published nowadays. Case control also have seen. Some RCTs are ongoing as such, and some have been published. But more needs to be done for have more faith. Community mobilizers I have already mentioned earlier. The standard treatment guidelines they are being released. One was released this morning also. But just like the allopathic system, STGs are there. ICMR has also made standard workflows. That also needs to be made for Ayush also. That when a patient approaches, what should the standard workflow at primary, secondary, or tertiary level? But an Ayush, of course, it will be slightly easier because you don't have primary, secondary, tertiary level. Every Ayush practitioner can do a lot sitting wherever he or she is. How to adopt these standard treatment guidelines or standard workflows by everyone? And for that, capacity building and leveraging technology and some kind of systems where monitoring and evaluation is part of it, that is also required. Public health principle I mentioned earlier. Digital health tools is again something which is very, very important. Teleconsultation, as Honorable Minister also mentioned in the morning, what we have mentioned very clearly is that the Ayush arms will be hubs for the Ayush for the Ayushman Arogya Mandir. CHOs can consult them, and they can be spokes when they want Ayush advice. So strengthening hubs in the Ayush institutions, that's I think is required more to be done, and that's where teleconsultation can be leveraged further. Emergency response protocols, because that's one area where all of us say that no, Ayush systems, they take time. There's nothing for emergency. So they are there, few of those. How we can improve on these protocols, how we can do capacity building for these protocols. Training for non-clinical staff again can be there, and continuous professional development. I would like to share here one more very interesting thing. Two of my batchmates are GI surgeons, and they learned the anorectal surgery, fistula in and hemorrhoid surgery from Ayush practitioners. So we were having discussion few months ago. They told me that youngsters are not getting trained, going for training nowadays. I said, what is the matter? He says there are very few of those Ayush who are confident to train. So that means even in the Ayush MDs, Ayurveda, when they're doing surgery and all, probably we need to relook at what kind of the curriculum and capacity and competency based needs to be built in. Because even not only my batchmates, even senior surgeons in the army and all whom used to interact, they used to learn from Ayush surgeons, especially for that area, because there the surgical procedures of the allopathy system always led to recurrence and also a lot of infections. So that's something, and another very interesting area which and a lot of our population suffers from that. It's a huge number. We generally don't discuss this kind of surgeries and all, but it's a huge number which suffers from that, and they don't know where to go. So they finally end up going to some quacks and all, and reversing their condition further. And in training capacity building, some kind of cascade model can be built in. National or expert level trainers can be there. We need to build a team of state level trainers. Identify state institutions. You have a lot of colleges and all. Identify where facilities are there, so that these state trainers are are utilized for that. We have created a Sashakt portal for monitoring. Similar kind of portal can be there, or even same portal can be used. Module can be added to for monitoring the training of all. And future is not only physical training, it is also leveraging the augmented reality, so that these kind of AR enabled videos can be there, and LMIS and IGOT, they can be there. And Sashakt, we are linking Sashakt with the LMIS of Ministry of Health, and that will get linked to IGOT also, so that this monitoring, the material is available. Everyone Aadhaar based logs in and does the course. Assessment is done, and monitoring can be done by the state team or the national team anywhere. And partnership with private sector for delivering skill based training programs with regulation and continuous professional development opportunities. That I think is another area which we need to strengthen when we talk of the capacity building. And technology, so e-learning platforms, mobile apps, I've already mentioned. Digital content and AI based skill assessment, which will be there. There's few best practices. Tamil Nadu's integration of Siddha practitioners in primary health centers, which is there. Gujarat has structured Ayush training program for COVID-19. ECHO has been used for Ayush telementoring, and IGNU has started Ayurveda digital diploma programs. But I think the ministry needs to do an evaluation also of that, how effective it is. And just to conclude, the way forward is, we need to institute a national training framework for Ayush. That should encompass all the areas which have been discussed since morning, and I have tried to do my bit to add a little bit to that. Strengthen infrastructure for overall and also for digital integration, foster institutional partnerships and community-centric approach. So there's the future of health system, as we all know, as we have been discussing, is integrative, inclusive, and evidence-driven. So I'm sorry, I keep on repeating evidence again and again. Although I'm not totally into EBM, because EBM is making it more and more mechanistic also, because Ayush systems and also our own old system where we used to talk to patient for long, that will become a casualty for evidence based. But that's a dominant paradigm, so we need to probably generate some evidence on that and link our own age old history taking and talking and understanding the symptoms in the individual, and then going for the treatment. Even our Hutchison taught about how to understand the symptoms and then examine the signs. In today's era, we are first doing the investigations and then calling the patient back to talk to him or her that what is your problem. So that system again, that once integration of Ayush probably will improve the allopathy also further, and we may go back to history taking and understanding the individual, and that's where community involvement is very very important. So that and the Ayush needs not be at a periphery now, and it needs to not only take the support of any system, rather become strong enough to provide the choice, and therefore that capacity building in all areas is required, and more integration and such kind of dialogues I think are required. Thank you very much once again for the opportunity and the honor. Thank you, sir.
Thank you, sir, for your guidance and for your strong attachment with Ayush and
बल्कि आपने
your.
जो कहा उसका एक जीरो ड्राफ्ट आप थोड़ा दीजिए
हाँ,
ट्रेनिंग फ्रेमवर्क जो आपने बहुत
आपने
सारे
बताया, yes sir,
वी
yes sir,
विल टीम
sir.
विल फर्दर
श्योर श्योर सर। सर आपकी परमिशन से सर मैं जरा चलूंगा, दो सुनना चाहता था स्टेट्स को भी। माय
हाँ,
फ्लाइट इज एट 8:30, तो मुझे 1.5 2 आवर्स लगेगा पूना जाने में। सॉरी फॉर दिस सर।
हाँ,
अच्छा नहीं नहीं सर, वो तो आपने बुला लिया, यहाँ फेलिसिटेशन हो गया सर। थैंक यू वेरी मच सर।
कितने बजे फ्लाइट है सर? सर अभी just 5 minutes. Uh, Sir, thank you for sharing your views and whatever you have heard from you. It was very wonderful. Now we'd like to hear from states. आ गए सर, तो आ नहीं रहे थे सर।